Hi, this is Jay Vanston, and this is a assignment 4 for assessment and evaluation in medical education as part of the Rowan Certificate of Graduate Studies in Adult Education. The objective of this presentation is twofold. The first is to summarize and synthesize the key points I've learned in this course, and the second is to apply these key points to the assessment of our fellowship program in palliative medicine. Our palliative medicine program is actually entering its second year on July 1st. So to begin with, what is assessment? Educational assessment is the process of documenting, usually in measurable terms, knowledge, skills, and values. Assessment can focus on the individual learner, the community of learners, and the educational environment. And this was actually borrowed from the first lecture and slide 1 of the beginning of this course. So why perform assessment? Well, Epstein in his article in 2007 pointed out 3 areas, or 3 reasons. The first is to optimize the educational experience of learners as well as teachers. The second is to protect the public by identifying incompetent physicians. And third, to provide a transparent, consistent, and fair framework by which individuals are selected for additional training or awards. There are 2 broad category of assessment types. The first, these are formative and summative assessment. Formative assessment is often done throughout the training period. It can be used as a guide for future learning. It can provide reassurance to the student that they are achieving their goals. It can promote reflection in terms of one's strengths and weaknesses and where he or she needs to put additional effort into their training, and also to shape values. Summative assessment is often provided at the end of a course or at the end of training, which provides an overall judgment about the fitness of the individual to practice. I had the opportunity to read Dr. Miller's article from 1990 on when he created these levels of evaluation and competence. And the quote that struck me is where he made the conclusion that no single assessment method can provide all of the data required for judgment of anything so complex as the delivery of professional services by a successful physician. Dr. Miller, however, did provide a framework upon which we can build assessment programs, and which we've discussed a number of times throughout the course and is referred to in almost all of the articles in our course, is this pyramid of clinical competence, starting with what one knows and progressing through what one does. In terms of the level of clinical competence, the base of the pyramid is 2 areas. The first is what knowledge, and the second is knowing how to use that knowledge. Excuse me, let me just jump back. In terms of knowledge, the question is whether or not the individual possesses the basic knowledge necessary to function effectively. This reminds me of my medical education in the 1980s, where our first year of medical school was simply getting knowledge into our head of anatomy, basic physiology, and we didn't have a lot of education in terms of how to apply that knowledge. The second level of the pyramid is knows how. That is that one can obtain data from a variety of sources, analyze and interpret the data, and develop a rational diagnostic or management plan. The next areas in the pyramid is the area of shows how. This is what evaluates or assesses an individual, what an individual will do with a patient with a particular problem. And the highest level of the pyramid is how a person does or how they act. And the assessment in this area determines whether an individual does the right thing in the real world. Some considerations that I took away from this assessment is that as one moves higher on the pyramid, our ability to assess the individual becomes more complex and more difficult. Although changing, the assessment of knowledge continues to dominate current institutional and specialty board examinations. And this is unfortunate because, as Alfred North Whitehead said, there's nothing more useless than a merely well-informed man. In terms of developing an assessment program, there are certain core features of that program, or a well-designed program. One is a clear understanding and assessment of goals. This is the first and most important step in developing an assessment program. The second is identifying and coming to a consensus on what assessment areas are essential, what assessment methods are going to be used, and also how the outcomes of that assessment methods are going to be analyzed and used for improvement. I think what is critical in any assessment program that is actually seen as a dynamic process whereby there is a continuous cycle of improvement. And I was reminded, as they were talking about this in assessment, was the Institute for Healthcare Improvement's model of kind of plan, do, study, act of rapid cycle improvement, where one starts with different ideas on how to improve a process, that you implement those ideas, you study the results, you make an assessment, and change what you do the next time. And you continue over time to use the cycle of improvement to result in a program that is solid and achieves its goals. Another area was assessment techniques, and I'll get into those in more detail as we move along here. But the core concepts of any assessment technique is the test reliable? That is the degree to which measurement is accurate and reproducible. Is the assessment tool valid? That is, does it measure what it claims to measure? And more recently, factors that have been taken into account include acceptability, and that's acceptable to the faculty and institution, that method, that it has a true educational impact, and finally, in this day and age, is it cost effective? In terms of different assessment methods, the first, as you recall, the first layer of Miller's Pyramid includes the area of knows and knows how. And this is where written examinations have been shown to probably be the most effective. However, even within written examinations, there are different types. The first is context poor, which reviews basic factual knowledge. These often include true and false questions or multiple choice questions, or context rich examination, which allow for more complex cognitive processes, much more characteristic of individual practice. These can involve completion tests, extend or modified short essays, or essay responses. The strengths of a written examination is that they can encompass many content areas. They can be administered in a relatively short period of time in a standardized way. Multiple choice questions and true-false questions can often be graded by machine, so it can be efficient and allow for a broad evaluation of knowledge. The weaknesses of written examination, however, is that they capture only the lower levels of Miller's Pyramid, and also using passing grades as determined by such techniques as the Angoff method described this year, merely assure competence, not excellence. Some other points that I took away from this was that, and learned, was that creating effective test questions requires considerable training experience. It is not an easy task. It is time consuming and takes a good amount of time to develop effective questions. And that although an accepted method for assessment, ongoing research is still needed in this area. For example, the article by Schneider et al. Revealed that 3 multiple choice answers was equivalent to 5, thereby allowing for more content areas to be examined in the same amount of time. The next higher level, and we start to get into areas of evaluating action, is when one shows, how do we assess that one can show how to do something? And this appears to be best evaluated through various forms of simulation. And simulation is kind of a broad category. It can involve something as simple trainers, such as the Resusci-Annie used for CPR training, or ophthalmic slides, where an individual can use an ophthalmoscope and look through an eye and see slides of different types of retinas and make a diagnosis. This can move from simple trainers to objective structured clinical examinations, which will require multiple stations that are looking at individual kind of interactions between physicians and patients. And this can move on to high technology simulator, which often use expensive robotic type devices that can simulate many clinical situations. The advantage of simulation is that one can practice critical skills in a safe environment, that one can assess a practitioner's skill without putting patients at risk, and it allows for repetition of attempting particular skills until one can achieve competence. What I find interesting in simulation is that it also allows for errors to play out, that one can allow an individual to make a mistake and to follow through and see the consequence of their mistakes without the attending physician or supervising physician have to step in. In the real life, obviously, if the resident begins to make an error, the attending physician must step in quickly to prevent that from harming the patient. And another advantage is that these can be used for both formative and summative evaluations. The disadvantage of simulation, some of this is from personal experience, is that it does require a great deal of preparation. That any simulation program or exercise that develops requires regular evaluation and scheduled updates to assure that it is up to date. For example, the OSCEs that are used are often that you require multiple stations to be effective. In the literature that we reviewed this in this course, people need 8 to 10 stations in order to provide reliability and validity. The logistics of organizing and implementing a OSCE exercise is quite difficult. You need to have patients, you need to have organization, you need to have schedules, students attending, physician supervisors need to be available, so it being difficult. And the OSCE can only focus on certain aspects of the physician-patient encounter. And finally, many simulations are expensive, and one can even just look at the high-tech simulators to show how much the cost can be involved. Another thing I took away from the discussion simulation is that technology cannot be an end unto itself, that just because you have a $500,000 simulator does not mean it actually can be an effective teaching tool, and that simulation must be seen as simply as a tool to meet the overall learning objectives, and that one must take into account the educational impact of simulation and the cost involved to the institution and practitioners. Finally, the highest level of Miller's period involves assessment of what an individual does in the real world or action. This is the highest level of Miller's pyramid, and it involves workplace-based assessments. And workplace-based methods of assessment target this highest level of the pyramid and collect information about a doctor's performance in their everyday practice. It is the most difficult form of assessment, but also the most powerful, because it provides greater authenticity since one is measuring and evaluating what is actually being practiced. There are a number of methods that have been developed. One is direct observation of procedural skills. This can be quite useful in residency and for example, surgical training, where one evaluates the procedural skill in individual engagement, that one can evaluate various procedures throughout the year, and it's undertaken during everyday work and involves a structured checklist to assure that the individual is acting in an appropriate manner. The second area is the mini clinical examination exercise developed by the American Board of Internal Medicine. It is a 15-minute snapshot of a doctor-patient interaction, and it allows for multiple areas to be open for assessment. And anything from history to physical exam to professionalism to communication, all can be assessed with the use of a very simple tool. It can be used in multiple settings, including the inpatient and outpatient setting. And multiple observations by different observers over time can increase the validity and reliability of the assessments. Finally, there's the area of case-based discussion, that this is a structured discussion between the trainee and supervisor. It allows for an assessment of higher order thinking, and one can spend more time understanding why a student acted in the way they did. And as a side benefit, it allows for an assessment of clinical documentation, which is increasingly important in the 21st century. Some of the challenges of assessment at this level is that how does one grade a case-based discussion, for example, or a mini CEX examining professionalism? We do not have clear standards for many of these measures, and faculty education is often lacking. I was surprised when we did not surprised actually, but assignment 3 was eye-opening in the sense that even though we have attending physicians who are experienced, who are interested in education, their assessment of the same scene often resulted in different evaluations. And I think the most important thing and the challenge of assessment, this type of assessment, is to instill a lifelong desire in the resident, a physician, or medical student to continue to assess their own activities and to improve. Other assessment methods which were reviewed and I think were quite useful is a 360-degree evaluation. Reflections, including essays and group discussions, I think are critical to professional development as well as personal development in medicine. And finally, portfolios, which allows a person to begin to develop a picture of their professional lives through organizing and recording their different activities. So some conclusions that I took away from this course is that assessment is absolutely critical to medical education. Without it, one can't continue to improve. The most critical step in developing an assessment program is the first. That is clearly defining what it is that is being assessed. That no single tool for assessment will suffice. Miller's period provides a solid framework upon which to build an assessment program, but multiple tools are required at each level of the pyramid, and multiple assessments by multiple observers over time is absolutely essential. Faculty development is critical to the effective establishment of an assessment program, and I have to applaud the Rowan program, the Certificate of Graduate Studies program, because it is the first step in beginning to educate physicians in how to design and assess educational programs. And although there has been considerable advances in the area of assessment over the past 25 years, there's much that needs to be learned. In terms of the Palliative Medicine Fellowship Program at Cooper University Hospital, it is now entering its second year. The strengths of the program is that it has a broad array of clinical challenges. There's a high volume in both the inpatient and outpatient setting, and there will be a ratio of 3 attendings to 1 fellow in the coming year. And finally, there's a strong commitment to education. In terms of assessment, though, we do have a number of challenges. Up to this time, it's been based on educational milestones and intermittent use of mini CEXs. However, we really need to start thinking about this in terms of Miller's pyramid. In terms of the areas of knowledge, both in what the fellow knows and knows how to apply, we need to have formal assessment of knowledge on a periodic basis, or a regular basis actually. And unfortunately, there are limited resources at this time. The American Academy of Hospice and Palliative Medicine has HPM Pass. However, this has gone off, is no longer valid at this time, and a new series of questions being developed. In the area of Shows How, we certainly should consider tapping into the internal medicine residency program at OSCEs. And manpower, however, is an issue with the development of simulation exercises for our fellow alone. Because as we noted in this course, these take a lot of time and development, and you need multiple OSCEs in order to make a valid assessment. In terms of workplace assessment, I think this is an area where we have the greatest opportunity to get good assessment of our fellows. It certainly needs greater emphasis throughout the year on the mini CEX, and we should develop a systematic way of doing case-based discussions in a more formal way as well. And finally, I was intrigued by the development of having our fellow develop a portfolio this year. That can not only help her understand her professional life, but also to use that with future interviews. And certainly more frequent 360-degree evaluations may help us to identify areas where our fellow can improve. So that concludes this presentation. I want to thank Dr. Hasid as well as the faculty of Rowan University for taking the time and putting up with a bunch of physicians in terms of training and education, and I look forward to working with you in the future. Thank you.